case. And the case will simply help guide the tester. So the first thing that you're going to do is you're going to tell me 2 red flags. And I want them to be regionally specific red flags because that's one of the bubbles in the patient-centered approach. Any red flags, you got to get them out of there. So what are your CV specific red flags? Splinting. Splinting's a big one. Okay? Dizziness falls under what umbrella? VBA. So any of the VBA signs or symptoms. Okay? So you can't give me 2 VBAs. So you do have to know all the D's or the B's depending on your slide. That's a joke. All the N's and the A. Alright, so if a patient's coming in with ataxia, that's kind of a red flag. You want to figure out why that's happening. I gave you my patient example. My patient showed cranial signs. So VBA signs are cranial or cerebellar signs. So if you give any of those, it's either going to be a cranial or cerebellar sign. Right? Ataxia, cerebellar sign. Drop attacks, cerebellar sign. What are your cervical red flags?
Splinting.
Why would someone splint?
Fracture.
Where is the dens? C2 part of the CS. If I'm telling you there's a CV and a CS. No. So is splinting a red flag to the cervical, lower cervical? No. If you're treating someone's lower cervical and they start splinting in the clinic, is that a problem?
Yes.
Yes. All right. So yes, you are correct. No matter who you see, if you see someone's foot and they're splinting when they go to turn their head, it's a red flag, but not really for the foot. Right? Well, actually, it might be. Maybe they're getting referred symptoms to the foot for a myelopathy. All right. But for the practical, I want regionally specific red flags. So we went through the CV regionally specific red flags. What are your CS regionally specific red flags? See, bilateral loss of rotation is going to be the dens. Why? Any joint does most of the rotation. But if you're treating a patient for anything and they have gross bilateral loss of rotation, it's a bit of a red flag, but it's CV specific. Multi-segmental. Upper motor neuron. Those are all upper motor neurons. So positive, so again, that's your category. So you can't say positive Babinski, positive Huffman. They are correct, but they're both upper motor neuron. What's another upper motor neuron? Hyperreflexia. Clonus. These are all upper motor neuron signs. These are all red flags. They are a red flag everywhere, but we're calling them CS specific. Okay? I realized I did forget one more CV red flag. Happens in this. Can happen in the scan. But it's not a red flag. That definitely is very alerting. It's not a red flag. It's severe pain in the back of the head, but that's usually going to be post something. So you won't see that straight on. But yes, if they get that, that's a big red flag. But that's going to usually be, they told you that post manipulation or after you treated them, it happened. That's not so good. So that's a good answer, but not for the practice.
Instability of C1.
Instability of C1, and what will instability of C1 present as? Potentially. What are we going to see? Yeah, you might see loss of rotation, sharp person. So before you even get to the sharp person, if you're doing a scan and they present with quadrilateral paresthesias, just from the neck flexing down, that's a red flag. I'm calling it a CV red flag.
With neck flexion?
With the flexion, yeah. Okay. So your CV red flags, which are in your notes, but we're just going over. Any VBI sign, so any cerebellar or cranial sign, symptom, is a red flag. Quadrilateral paresthesias, splinting. Those are the 3 that you're allowed to say. For the CS, multi-segmental paresthesias, multi-segmental numbness, testable numbness. Okay. From your slides, odd symptoms in the extremity post-trauma. something that doesn't fit a pattern, actually it might not be a problem, but it might be. So if they haven't seen a physician, you want them to see the physician. Set up a motor on it. Oh, and then, which is true for lower and upper, what's the trifecta?
Testable numbness.
Testable numbness,
Taking weakness.
fatigable weakness, which one? Hypo, loss of reflexes. Loss of reflexes is a deadening nerve root. Testable numbness is a deadening nerve root. Okay? Trifecta. It's the trifecta. It's the red flag trifecta. If you have testable numbness, fatiguing weakness, and loss of reflexes, they need to see a physician.
That's for upper
There's
and lower.
a good chance that a nerve root's getting crushed.
That's for CV and CS.
Well, the thing is, you're not going to get that for CV. So we'll say that is specific for CS. All three of them is considered one red flag. So the red flag for the CS, upper motor neuron signs, and then you got to tell me one of them. Multi-segmental testable numbness or even multi-segmental paresthesias can be a red flag. The trifecta. Absent reflexes, is that a red flag? On the extremities specifically?
No.
Not really, it's pretty common. Do you want to log it in the back of your head because maybe it's significant? Sure. But it's not uncommon to be missing one or both sides of your reflexes in the upper extremity. The other thing I said was odd upper extremity symptoms post-trauma. Just because it doesn't fit a pattern, something's off, that's not a good thing. The other thing is, this was kind of a side, you could use it on the practical, but a loss of bowel and bladder. If your patient comes in and they're expressing that they have a recent loss of bowel and bladder, they need to see a physician.
Isn't that upper motor neuron?
Yeah, it could be, it could fall under upper motor neuron. But because it can come from a variety of places, right? So it can come from a cervical myelopathy. So if you can get compression of the cord, you get upper motor neuron signs, so that is considered an upper motor neuron red flag. That's good, I'll move it out of the list. Put it under that category. All right, how about thoracic? That's definitely a finding. Is that a red flag though? Is it a red flag though? It's definitely very notable. So the loss of rib expansion, definitely very notable. And if you start to see other signs that may, say osteoporosis, ankylosing spondylitis, it definitely is a yellow flag. Proceed with caution. Red flags are like they shouldn't be in your office.
Loss of
Okay? So red flags for thorax.
Chest pain?
Chest pain, what kind of chest pain?
Stabbing.
Stabbing. Sharp stabbing chest pain. Pain upon exertion. Pain between the shoulder blades upon exertion. Possibly associated with a shortness of breath or a cold sweat. What are you worried about?
Do those all count as separate ones, or the stabbing pain?
If you say thoracic pain, you have to explain more. So thoracic pain, intense thoracic pain, or even thoracic ache between the shoulder blades associated with a shortness of breath upon exertion, possibly associated with pallor or cold sweating, that's one. You have to do all of them. But if you tell me sharp pain, I'm going to want to know more. If you tell me pain between the shoulder blades, I'm going to want to know more. Upon exertion, maybe with pallor or something like that.
What are the other two?
Bilateral slough, what do you find? Tingling, where? Both legs. Okay? It's a red flag and kind of a yellow flag, but we're going to keep it on the red flag because you really got to be careful and they're probably going to want to see someone about it. Okay? It can, but not really in the thorax because testicle numbness is not always present because there's so much redundancy in the segment, and your reflex may not show up, especially if it's an upper reflex, and you're going to get, the muscles are segmental innervated, so you're not going to get testicle weakness. So the trifecta doesn't count in the thorax because we can't find it.
For a slump, it's only tingling, not numbness or weakness or.
No, it's tingling. Yeah, I'm going to say only tingling. The fact of the matter is, if you test for strength Or you test for upper motor neuron signs and you do the stop and they get worse, that is a red flag, but we're not going to count that. We're just going to say bilateral slump, leg tingling, red flag because of thoracic compression. We said sharp pain in the thorax. Give me a little more. No, we did that one. So that one's covered. So that doesn't have to be sharp pain. That could be an ache between the shoulder blades. That's the most common female presentation for heart attack.
Left shoulder down the arm.
Oh, that's another presentation of heart attack. So out of heart attack, what's another red flag? Sharp pain, since you said sharp pain earlier.
Pain with breathing.
Sharp pain with breathing. Potentially a pneumothorax. So sharp, deep pain, especially increasing with exertion, kind of in the lung area. Feeling almost like they have an itch under the lung and they can't catch their breath. Maybe a sign of, not a pneumothorax, that's pulmonary embolism. But a pneumothorax, if they have a rib puncture, probably if they have a pneumothorax, I'm going to get to you, but if they have a sharp pain on exertion, potentially it could lead to a pneumothorax. So that's definitely a red flag. But you're not often going to get that. I had a patient with pulmonary embolism. It was actually seeing one of the PTAs in our clinic. She called me over because I think he was for back pain, and he was having an odd pattern of pain, and he was having trouble breathing. He was talking about his construction guy. And he was on the rafters when he was walking. He was like, I get to the top of the stairs and I feel the pain through here. And he couldn't inhale through that area. It just wasn't expanding. So I sent him to the doctor right away. They did a scan and found a pulmonary embolus. They put him on meds right away. So if you wouldn't have caught that, he may have died. So you want to listen for those patterns. Err on the side of caution, or get a senior therapist if you're not sure.
How would you allow intercostal muscle sign? Or
Because the type of pain, so it's a qualitative thing. That's why you might need to have a second look at it. But if it's sharp and intercostal pain with breath, it's not going to be sharp. If they turn and they get a kind of sharp stab and they point right to the joint, and you strum the joint, it's probably the joint. But if they have a rib fracture and they're having movement, depending on their history, with inhalation they feel like they can't move, but the lungs are still moving. That area kind of guards a bit. With the pulmonary embolism, you don't see as much muscle reaction guarding. Their lungs just aren't expanding. So there's a qualitative difference to it. Okay? So we'll say sharp pain with inhalation. No. Pulmonary embolism, pain with inhalation, pain with exertion. It can be sharp or it can be like a strong, deep ache. So anytime someone starts to describe this deep ache, like is it here? No, it feels deeper. That's a little bit of an alert. Not quite a red flag, but it can be a little bit of an alert. Okay? That is another one. It's a sharp flank pain. So if they get pain down here, they get sharp pain down here, and then it rolls around like this. That's the common pattern of kidney. So if they have a kidney stone, here, around there. Okay. You can do, if you put your hand over about where the kidney is, so on the lower thorax, if you do this, it's just a dump test, and they have pain with that, so it's dispersed, so that that's one of the ways you can stress the kidney. That can be a red flag, yeah. It's usually not an emergent one, but chances are you want them to see their Okay, so you have to list 2 of the red flags, okay, regionally specific red flags. And then you'll be responsible to perform a movement assessment. So if it's CV or CS or thorax, okay, you're going to do flexion extension, then you're going to do either side bending or rotation. Who are you doing side bending for? Lower cervical. Who are you doing rotation for? Upper cervical. Thorax, I'll leave it up to you. Okay, we mainly did it with rotation, so probably best to do it with rotation. Then you're going to do combined movement. Okay, so your combined movement is going to give you a quadrant of interest. That's it. And then you're going to do your pivot. So you're going to demonstrate flexion extension, so movement assessment, flexion extension. You're going to choose rotation or side bending, depending on your region. And then we're going to say you're limited to this rotation or you're limited to this side bending. So then you say, okay, I'm going to do my combined movement. I found in the flexion extension assessment, they were limited in flexion. I found that they were limited in right side bending, so I'm going to do flexion right quadrant and see if that's true. You may need to check the other quadrants, but you're like, oh, that holds true. Their flexion right quadrant is limited. Then what are you going to do? Pivot them. We'll tell you a segment. Pivot them, then what are you going to do? Paddle. That's it. From the paddle, you'll turn to us and say, you'll demonstrate the paddle, and we'll say, the paddle was positive for a joint limitation, or it was negative for a joint limitation. If it's positive for a joint limitation, what's the treatment you're going to demonstrate? Joint mode. Almost exactly. However, you do it with a joint focus. So you're going to tell me that you're doing a joint, the positive paddle, and then you're going to show me the joint mode that you're going to do a joint treatment. You get a positive pivot, then you turn to us and say, the paddle was negative. What treatment are you going to demonstrate? Do muscle energy. Okay? So it's going to be the same position that you would do the mobilization. However, you're going to show me how you do a contract relax. Muscle energy for that area. Okay? Hold on one second. No, sorry. Okay. If they have a positive pattern, you're doing a joint technique. If they have a negative pattern, you're going to talk them through an align, connect, cue so they can move through the motion. Not the. No, okay. You know what? I'm going to change this right now. So, because that's how I tested it last time, but it makes more sense this way. So, if you have a positive pattern, you do a joint technique. If you have a negative pattern, you do a muscle energy technique. Okay, so you're going to do one or the other. Okay. On your sheet where it was D that I had last year, had everyone do a muscle assist technique. Now everyone's going to do a connect and move technique. Okay, that just makes more sense in the flow of treatment. So, say again. So I'm flipping those two stages. So you're going to do the combined movement, you're going to do the pivot, you find the pivot, and then you're going to do a paddle. The paddle is either positive or negative. If it's a positive paddle, you do a joint technique. After you're done doing the joint technique, you're going to sit them up, and you're going to teach them to align, connect, and then move into whatever the quadrant of interest was. Okay? If you're another person, you do the pivot, positive pivot, you do the paddle. I say the paddle is negative. You say, okay, I'm going to do a muscle energy technique. They do the muscle energy technique. After that, you sit up, you're going to do align, connect, move into the quadrant of interest. Okay? That just makes sense in the flow of treatment. And then you have to do a thoracic T4 extension manipulation. We're going to demonstrate one manipulation. It has nothing to do with the patient. You're just going to do a manipulation to demonstrate that. Okay? So I'm going to change the form that I posted for the practical. I'm just flipping. So everyone is going to have to do an align, connect, and move. All right? Everyone's going to have to do a combined movement, a pivot, and then a paddle. But then depending on what we tell you, you'll either do a joint technique, joint mode, or you do a muscle energy technique based on the pivot and income. Got it? Okay. Everyone say yes, I got it. This is what we did today. Yeah.
So before your pivot, you're saying perform the following movement assessments, reflection assessments. So as the patient active, then you do passive overpressure, then you do MMT.
No. Yeah, that's what you would do in the clinic. What you're doing for the practical is just the movement assessment. They're going to do flexion and extension. Okay, so you're going to see, and then you can tell me if you're checking to see if they're going all the way. You just want to know if they're limited or if they don't want to. You're just doing the movement portion of the scan. You're not going to do the overpressure resistance.
The last phase is quadrant only, or you're doing both sections?
No. Quadrant for the manipulation.
Not manipulation.
Oh,
when you're doing the assessment.
No, not doing rotation and latection. No, you're not doing rotation. You're just doing combined movement. Flexion, extension, and you said the rotation was limited, so you do extension, rotation to get a quadrant of interest. That's it. I want you to get to a pivot and then a paddle. That's it. Okay? So I actually want it to be pretty straightforward. I'm not going to do that. Okay? And your manipulation, which has nothing to do with your case, is a T4 extension manip, lying down just like we did in class. Okay?
Extension or questions?
T4 5. Extension manip.
So for D here, you have muscle assist technique. I'm assuming that that's muscle energy. So you're switching that with what you would do if it was if happened was negative.
Yes. Yep.
For the combined movement of the thorax, the one's specifically rotation, or does it matter? Rotation or side?
You can do rotation or side bend. Okay, whatever you feel more comfortable with.
I think it's the same question, but I'm talking for neck, for cervical, or for thoracic. So do you mean, what do you mean by combined movement test? Do you mean we've already found the flexion and extension, which one bothers the patient. Then we would take it through the quadrants to see which quadrant is most effective.
How do we do combined movement testing in the neck? It's like an H&I, but it's not really H&I.
Right.
So we flex them and side bend them.
Yeah, so you're finding a quadrant, and if that would bother them, I go to extension. And,
You find a quadrant of interest.
right.
So you can check all 4 quadrants, flexion right, flexion left, extension right, extension left, and you're going to find a quadrant of interest. It should match that when you did flexion extension, you found a limitation. When you found side bend, you found a limitation. So the combination should match. And on the practical, it will. In life, it may not. Okay? Yes, thank you. So if you have the CV, you're doing rotation. So what's your combined movement of rotation?
Side bend rotation.
Flexion rotation or extension rotation. What's your pivot for the CV?
Depending on what your quad
Is there a pivot for the CV? Not really. The combined movement differentiates. Right? So the reason for a pivot is to localize a segment. Your combined movement in the CV localizes between OA or AA. Okay? So then from there you do your pablum, and you can do a pablum for either OA or AA. Okay? All right.
That's all practical?